Good morning to all of you. I am Professor Rajendra Prasad. At present, I am a Director Medical Education and Head Department of Pulmonary Medicine at ERA's LUCNOW Medical College and Hospital, Lucknow. Now it has become university now. I have been former Director, VALLABH PATEL Chest Institute, Delhi, and I have also served King George Medical University, Lucknow for nearly a 4 decades. I remained head there. Now this is the third of my series in interesting pearls in pulmonary medicine. I will share with you some of the interesting cases which I have come across in my 4 decades of clinical career as a pulmonologist, and I have worked with these cases, how I have worked these cases, what I have diagnosed, I am going to share with you. The first case was a gentleman about 31-year male. Actually, when I was in KGMC, this case anyhow was admitted in some other department with the complaints of hemoptysis 1 year back and then 15 days back, about 50 to 100 ml. He had also right-sided chest pain, loss of appetite from 1 month. Somebody has already prescribed him anti-TB drugs for about 9 months without any response. When he received 9 months of treatment and when his hemoptysis recurred, then somebody referred this case to me for bronchoscopy to know the cause of hemoptysis. And this was the X-ray. He came with only this X-ray at that time. He said that he had X-ray, but no records were available at that time. In chest X-ray, you see it shows some radiopaque shadow in the right lower zone, which nature of which is not very clear. He was 31-year-old man. So, in our mind, we were not sure what is actual diagnosis. And this was the CT picture at that time. Again, it shows that shadow in CT scan, some pleural thickening, not clear by CT scan. And when we performed bronchoscopy, when he entered into the right lower lobes, to our utter surprise, you can see here 2 white shining structures are visible in basal segments. At that time, I was myself doing bronchoscopy and I was not sure what these white shining structures are. So, what we did some aspiration from bronchial aspiration from this side. And when we put that aspirate into the test tube, so what you can see here, we find there is a membrane-like structure. That has given to some hint to us, could it be a ruptured hydrated cyst? And then we ask him to bring all the X-rays, old records. Next time when he came with the old records, you can see in this X-ray, there is some cavity present in the lower zone. And at that time, even CT thorax was done, and you can see there was a cystic mass in the lung that has clearly saying that possibly it was a ruptured, it was a hydrated cyst, which has ruptured finally, and this was the X-ray picture before. If you see this X-ray, nobody could do any fault to think that this could be an hydrated cyst. What I am trying to say, since the doctor, he could not supply whole history, but in the history we could find that he has been X-rayed before. On this X-ray he was started anti-TB drugs without any response. Now if you see the whole picture of him, it clearly shows that it was a hydrated cyst which has ruptured, and during bronchoscopy we could find those membranes. And finally, what we took some biopsy also from around area, and that revealed the hydrated cyst with associated pneumonitis. What I am trying to say with this very single case, that you must have understood by now that whole history taking is very important. Whole sets of previous records are very important. If you see the X-ray is there, if you see the previous CT, if you have seen this before doing bronchoscopy, you could have diagnosed very well. But records is not available to us at that time. He belonged to very far-flung area. So next time when he came with the full record, that is why I advise every chest physician, please see the case fully, whatever records are available, go into them thoroughly, and then before planning for investigation and diagnosing. So this was and ultimately diagnosed as ruptured hydrated cyst and presenting like a white structure in the lower basal branches of the right lower lobe. This is another case, 25-year female, mind it. Cough with expectoration, sometimes purulent, for last 10 years. So she was sick for last 10 years. You can, history could be very important. Then she again had recurrent hemoptysis for last 5 years, breathlessness sometimes for last 3 years, non-smoker, no lymph nodes, no clubbing, because when somebody had cough with large amount of expectoration, with hemoptysis recurrent, one may suspect, and in this age 25, one may suspect as a bronchiectasis, but there was no clubbing. And again in this patient, in India it is very common to prescribe anti-TB drug without understanding the disease. So again she was prescribed anti-TB drugs for about 5 months without any response, and this is the X-ray picture. You can see in X-ray that the right cardiophrenic angle and to some extent the castophrenic angle, they appears to be obliterated, and the dome of diaphragm is not very clearly visible, but one thing is very clear when you see the X-ray, that volume of the right lung is less as compared to left lung. So one thing is very clear by seeing this X-ray, that there is something endobronchial is there, which is producing the volume loss, and possibly that lesion must be in either in the bronchus intermedius or in the lower lobes. What I am trying to say, nowadays bronchoscopy is very common procedure. Those days bronchoscopy has just started. So what we have done, we have to evaluate every case. You have to think before putting the bronchus inside, that what finding you are likely to get, and then what level you are likely to get. If I will advise my young chest physicians to go like this, then you will be adding to your experience. Just putting the bronchoscope and taking it out may not help you. We wrote an atlas on bronchoscopy first time in India with the Indian patient, that was released by former late President Sri Kalam Sahab in 2014, and that was based on our own cases, only because we used to study every case before doing a bronchoscopy. So we did, with this background knowledge, we did bronchoscopy, and you see in bronchoscopy, you find there is a polyp-like structure coming out right lower lobe, and it is pedunculated. You see, with respiration, it is moving, this polyp is moving. So, it is pedunculated probably. It is not simply a growth. So, what we did, and you see around that polyp, there was lot of pus present. So, what we did in this case, we just with careful, we punctured it, and after puncturing some blood came, but diagnosis was not possible. But it was very clear that it was diagnosed, it was like a polyp. So, polyp was, with the help of rigid bronchoscope, we have removed this polyp with the help of our ENT colleagues also we took. But unfortunately, at that time polyp disappeared, but polyp has regrown again. And finally, we advised this patient to go for lobectomy. So, this was endobronchial polyp. Now, this is another case, you find the hilar prominence on the left side, mainly on the left side. Usually in cases of sarcoidosis, we see that there is bilateral hilar lymphadenopathy, but not necessarily every time it should be bilateral. So, this case we are seeing as a unilateral hilar lymphadenopathy. We did bronchoscopy with the hope that we may get something in this case. So, when bronchoscopy was done, what we could find that there was quite vessels were very prominent, and there was some of the endobronchial lesions were appearing. What we say in sarcoidosis, even if the lesions were not visible, still you can do a endobronchial biopsy. But fortunately, in this case, the lesions were visible, and what we could find when we took 2-3 pieces of endobronchial biopsy, and that has shown the non-caseating granuloma. And when serum angiotensin converting enzyme was highly elevated. So, we diagnosed this case as a sarcoidosis, and we treated, and patient got well. What I am trying to say, not every case of sarcoidosis present typically. Sometimes it may be unilateral hilar lymph nodes, they may present, and you may have to diagnose. Another message with this is, when you perform bronchoscopy, although you can go for TBNA, although even endobronchial biopsy, it is said that even sarcoidosis has no endobronchial lesion. Even you can go with the normal endobronchial tree, you can perform biopsy, and sometimes we are. But here in this case, some lesions were visible, and we performed endobronchial biopsy and were rewarded as a diagnosis of sarcoidosis. This is another case when you find that he had problem recurrent hemoptysis. Most of the cases in our chest medicine, they come with the recurrent hemoptysis, problematic. And if you see the X-ray, there is some paratracheal mass like structure. CT thorax, the same mass is there. And when we, to know the diagnosis, what we did bronchoscopy, and in bronchoscopy you can see there is a black spot is visible, there is a whole black hole is visible. So, it was diagnosed as endobronchial sinus, and finally, we did take biopsy from around, and it was proven as tubercular, and he got well with the anti-TB drugs. Now, this is another case, about 30-year female complaining with cough and expectoration for last 6 months, fever for 6 months, decreased appetite for 5 months, and breathlessness for 15 days. So, if you see the X-ray, first X-ray was practically within normal limits, and she was prescribed anti-TB drugs for about 6 months without any response. Somebody has prescribed her. As I said, in India, it is very common practice. We don't understand the disease, you prescribe anti-TB drugs. That's not a proper. And after some time, this is the X-ray which shows that there is some shadow in the right lower zone. Again, nature of disease was not very clear, even with CT scan, but there was some pneumonitis-like shadow, even some lymph nodes are also visible. So, what we did a bronchoscopy in this lady, and we could find in bronchoscopy you may find a nodule. You may find a nodule in the right endobronchial tree, and this nodule was, you can see here, and this is very clear when you use larger views. And when what we did, we punctured this nodule, and some caseous material came out, and that caseous material showed positive for acid-fast bacilli. When we did after a bronchoscopy, we just punctured that nodule and caseous material came out too, and when we put her on ATT again, she responded. So, whatever I am trying to say, if something like lesion is there endobronchially, and if you don't tackle that lesion, ATT may not, patient may not respond with ATT. This is another case, 26-year female, presented with cough, expectoration, high grade fever for 15 days, breathlessness for 15 days. She was diabetic, you can see sputum smear was negative on 3 times, and this was the X-ray picture. In X-ray picture, something like mass like shadow visible on the chest X-ray, but chest X-ray is not the final answer. This is the lateral view of the same lady. It is present somehow posteriorly, shadow is posteriorly placed, and then this is the CT picture when there is a quite thick wall cavity, and when we did bronchoscopy, there are some endobronchial thickening, there is a mucosal edema, and we just took bowel fluid and it was positive for AFB. What I am trying to say, young lady presented with short duration of symptom, sputum smear was negative, but bowel was positive for AFB. A role of bronchoscopy, taking other specimens to diagnose tuberculosis in sputum negative pulmonary tuberculosis. So, that was after the treatment you find that shadows has cleared. This is another very interesting case. He was a 46-year-old male and with complaints of dysphagia. His main complaint was dysphagia, loss of weight and appetite and recurrent. Why he was referred to us? Because of the recurrent hemoptysis. So, for dysphagia, somebody say barium swallow, and when they did barium swallow, what they could find that the whole endobronchial tree was visualized. So, dye went into the endobronchial tree. Then CT thorax, you can see here very clearly that has shown thick esophagus, and not only thick esophagus, you can see the communication between trachea and esophagus. So, for hemoptysis he came to us. So, what next investigation? We did perform bronchoscopy, and in the bronchoscopy again you find there is a hole in the lower end of trachea, and there was a lot of multiple nodules around that hole. So what we did, we took some biopsy piece from here, endobronchial biopsy, and that has shown the C esophagus. Something is there is a tracheoesophageal fistula, and that C esophagus was infiltrated. Then we asked the patient to go for OGD, upper GI endoscopy, and where clearly it has shown there was a CA esophagus. So, C esophagus not diagnosing properly to begin with, and ultimately creating a tracheoesophageal fistula. This is possibly a last case in this interesting pulse, very interesting case. I am following this gentleman for last 35 years, to be very frank. First time I saw him around 80s, so it's about 37 years. And believe me, this case has taught me a disease. Good point that he is still alive. He still comes to me. When he first came to me in 80s, he had history of, at the age of 20, he has history of 10 years of breath. It means his breathlessness started at the age of 10 years. So he has early onset breathlessness, indicating that he may be a case of bronchial asthma. Then at that time, why he came to us, not for asthma, but he came to us because he had fever, he had cough, he had hemoptysis, again hemoptysis. That's why somebody referred to him to us. And you see, this was the X-ray in 81, which shows some homogeneous shadow, especially in the left lower zone and middle zone, and some shadow in the right lower zone, and which has cleared in about 6 weeks of time. Again, then I went into his whole records, and we found that in 83 he developed again shadows on the right side, clearing again after about 6 weeks. Then in 84 he again symptomatic, and now the shadow has moved into the left upper zone, you can see very clearly, and in 84 again that shadow has disappeared and shadow has moved to left middle zone. And in 91 another episode shadow has moved in the right middle zone, peripheral area, and that has cleared. And so in 93 again shadow has come into the right upper and middle zone. So in 2004 he had another episode where shadow has come into the left lower zone. So what you can see in this X-ray, this pneumonia like shadow, it's a walking into the every zone of the lung. And at that time I named it as walking pneumonia. We published many papers out of this patient, and this we are still following him. This is X-ray of 2012, and then so we have presented this case at many forum. I have delivered many orations on ABPA because this patient gave me lot of learning, and we published one of the paper, walking pneumonia, fleeting pneumonia we can say, in patients of asthma as a clue to diagnosis of ABPA. Clubbing was also found in these cases later on. And you see all the investigations of ABPA, you find the most important is eosinophil 14%. And I used to say, for any clinician, if some patient on the background of asthma presenting like either shadows mimicking tuberculosis, pneumonia, and especially if the shadows are fleeting or walking in nature, and there are many more shadows. And if in this scenario you found that eosinophil count is between 10 and 20%, don't use diethylcarbamide. They are not cases of tropical pulmonary eosinophilia. I have seen misuse of diethylcarbamide like anything in this country. So, this eosinophil was 14%. And so, Montus test was negative. Sputum smear and culture were negative for MTB, for Mycobacterium tuberculosis. Sputum smear for fungus was positive, and even culture it shows Aspergillus fumigatus. We went further. We did a skin test to see whether he is sensitized to Aspergillus fumigatus. Yes, Aspergillus fumigatus type 1 and type 3, both were reactions were positive. And then we performed total IG, it was very high, and then IgE and IgG was also against Aspergillus fumigatus was highly elevated. And at that time we used to do lot of bronchography, and bronchography you can see there is a proximal dilatation of the bronchi, what you can call it as proximal bronchiectasis. He is in a regular follow up with me. You have to gain confidence with the patient, otherwise patient will run away from you and he will keep on changing the doctor. One of the study I did with asthma patients keep on changing their doctors, because either the patient is not clear or you have not given him the clear. So, but now luckily he is with me. I catch, he is very poor fellow. His father sells the very small shop. So, I catch hold of in 2007 just for my interest whether there is a proximal bronchiectasis or not. We got his CT thorax done, and you can see clear picture of proximal bronchiectasis, and this was the clubbing. So, we diagnosed this case again allergic bronchopulmonary aspergillosis. The allergic bronchopulmonary aspergillosis is the, if you see the aspergillus, how it creates disease in the chest, it creates disease if the person is atopic, it may create bronchial asthma simply, it may go to develop ABPA. So, these are the two conditions which are present under the atopic situation. In non-atopic, aspergillus can produce aspergilloma, can produce semi-invasive aspergillosis, can produce invasive aspergillosis, very serious condition. So, this was case of, this is the allergic manifestation of Aspergillus fumigatus. So, what I am trying to say, such patients will hardly require any antifungal drugs. Well, if the patient is not responding or you want to spare steroids, otherwise treatment of choice is steroids, oral steroids in such cases, and you see all the diagnostic criteria what Greenberg or Patterson has given, all the criteria were present. If you see from beginning, history of asthma, history of immediate cutaneous reactivity to Aspergillus antigen, current or previous pulmonary infiltrates, here the old X-rays. If you just don't bring, you can, if you have old X-rays, you can instantaneously think about this condition. There is elevated total Ig level, usually more than 1000, precipitin antibodies, peripheral blood eosinophilia, elevated serum Ig and IgG against Aspergillus fumigatus, and finally long-standing cases will develop proximal bronchiectasis. Proximal bronchiectasis is taken as very pathognomic for diagnosis of allergic bronchopulmonary. So, all the features in those 30 years, one case as I told you has taught me this very condition, and I have learned a lot from this patient. First treatment choice is oral steroids. So, we gave, and we have seen all the X-rays clearing after 6 to 8 weeks time, they are after the oral steroids. But in such type of cases, we have also tried itraconazole. Drug is not very rewarding, but some of the cases where you believe that it is recurrently occurring, you may try some antifungal drugs, but only problem is this, that Aspergillus is a ubiquitous fungus, so it comes and goes. Again it got, patient gets infection, patient gets Aspergillus, I mean they are lodged into the bronchial tree and they get exacerbation of ABPA. So, ladies and gentlemen, what I am trying to say with this interesting pulse, that to diagnose them, you have to be very, very good in history taking, you have to be very good in physical examination, you have to see all the X-rays available to the patient, not only one X-ray will make you, land you to the diagnosis, and many times you have to think of other investigations. Even you have seen TLC, simple TLC, DLC may be very informative, sometimes skin test may be very informative, otherwise in some of the cases CT scans and bronchoscopy and PFTs may also help. That is how you work up with these interesting cases of in pulmonary medicine. Thank you very much.